Okay, good afternoon, everyone. I just wanted to welcome you to this GECKO session, which is hosted by the Gastro Foundation in association with Project ECHO and the University of New Mexico. As you know, this GECKO meeting for fellows is held every Monday afternoon at 16:30. If you have any questions, you can post them in the chat, or there will be time for questions at the end. Dr. Robertson is going to be presenting on oncology specifically related to pancreatic cancer and colorectal cancer. And I know that it was very well received last year, and I think it will just give an oversight and sort of, sort of give you the stuff that you need to know as GIT surgeons and GIT physicians. Thanks very much, Barbara.
Thank you very much. I'm going to turn my camera off and share my screen. Can everybody see my slides?
That's great. We can see that perfectly. Thanks.
Okay. So I'm going to talk about the role of the oncologist in the management of colorectal and pancreatic adenocarcinoma to allow, actually aimed at the surgeons. I didn't realize there were physicians as well, but this is to allow you a little bit of insight into what we do here in oncology with these two diseases. This is my approach to the topic. I'm going to start with colorectal adenocarcinoma and talk about adjuvant chemotherapy for primaries in the colon, neoadjuvant treatment for primaries in the rectum, and then treatment of metastatic disease. And the approach to adenocarcinoma of the pancreas will follow more or less the same themes. The first slide shows the agents that are active systemically for patients with colorectal cancer. And I've divided them into three groups. We've got the cytotoxic or straightforward chemotherapy. Their action is on the DNA, and these have different actions depending on their chemical formulation. And then we've got the biological agents. And I put the immunotherapy agents in a separate category, but they probably belong with the biologicals. So when we talk about patients with colorectal cancer and adjuvant treatment, we're going to be focusing on these: 5-fluorouracil, capecitabine, which is also 5-fluorouracil, but given in an oral form, and oxaliplatin. When we give names to combinations of chemotherapy, so if we combine infusional 5-FU with oxaliplatin, we call that FOLFOX. When we change the oxaliplatin to irinotecan, we call that FOLFIRI. Capox and Peri is just the substitution of infusional 5-FU with oral capecitabine. And then we can give triplet chemotherapy, which is a combination of all three: 5-FU, oxaliplatin, and irinotecan. These combinations with an infusion of 5-FU all require a 48-hour infusion. And that means the patient must either have a peripherally inserted central line or a port, and then they get specially designed infusion pumps, which are a special type of plastic that's pumped full of the 5-FU and then administers the 5-FU slowly over the 48-hour period. So why do we give adjuvant chemotherapy for patients who have primaries in the colon? This is an adaptation of the AJCC staging manual, and you can see on the slide I've divided the stages into stage 2, which means node negative disease, and stage 3. And it's very obvious that the T4 stage 2 patients and the higher T and higher N stage 3 patients have a much worse outcome than the earlier stages. When this was recognized, an attempt was made to try and prevent tumor recurrence and prolong survival by the use of adjuvant chemotherapy. And we've made several changes over the last 30 or 40 years. In the early 1990s, it was traditional to give 1 year of 5-fluorouracil. We then discovered that 6 months of chemotherapy was not inferior to 1 year. In the early 2000s, oxaliplatin was added to 5-FU and showed improved survival. But the problem with adding oxaliplatin is that there's this potential for increased peripheral neuropathy, and some patients are left with peripheral neuropathy for the rest of their lives, which is not a pleasant experience. So the latest research, some of the latest research has been on trying to reduce the time of, or the length of chemotherapy. There have been 2 trials, one with stage 3 and the other with stage 2, looking at 3 as opposed to 6 months of adjuvant chemotherapy. There are a fair amount of complicated statistics done in both trials. There were non-inferiority trials. So this is just a summary of the basic findings. The centers that were involved, and there were many, in the stage 3 trial, there were over 12,000 patients. So the centers could choose to either give FOLFOX or CAPOX. And they found that there was actually a difference in the 2 regimens. If CAPOX was given, they could show that the disease-free survival for 3 months, it wasn't significantly non-inferior, but we'll go through the final conclusion in the last sentence. But if the patients were given FOLFOX, the disease-free survival for 6 months was significantly improved for 6 months as opposed to 3 months. So in terms of CAPOX, one of the statements from the trials said that despite the fact that the stringent pre-specified non-inferiority endpoints were not reached, the survival results support the use of 3 months of adjuvant CAPOX as a standard of treatment for most patients with stage 3 colon cancer who are suitable for treatment with CAPOX. The same does not apply to FOLFOX. If the center chooses to use FOLFOX, 6 months must be given. Some algorithms from the European Society of Medical Oncology guidelines. This is for the stage 2 patients. The patients with low-risk disease have an excellent prognosis, are not going to benefit from adjuvant chemotherapy, and should just be followed up. The high-risk patients, and there are 2 very specific features for high risk, those are the patients with T4 disease or where less than 12 lymph nodes have been seen by the pathologist. So as you saw from the previous graph, these patients have a much worse prognosis. So these patients should get adjuvant chemotherapy. They've put the option of 6 months here, but it is acceptable to give 3 months. And then if you've got someone sitting in the middle, intermediate risk, with these soft factors for a higher risk of recurrence, so it's lymphovascular invasion or perineural invasion or a high-grade tumor, you can offer them adjuvant chemotherapy, but then you'd give 5-fluorouracil alone. And we certainly don't have any evidence for giving that alone for 3 months. That must be given for 6 months. Microsatellite instability confers a better prognosis, so then one would tend not to give adjuvant chemotherapy if they only have these sort of lower risk features. And then for the stage 3 patients, they can be divided into low or high risk, but from this line in the middle, it is acceptable to give these patients 3 months. You could consider 6 months of CAPOX, but if you're going to give FOLFOX, again, definitely 6 months. And here at Robertson Hospital, where we're always concerned about resources and costs, we give our patients only 3 months of CAPOX. We're going to move on to treatment of adenocarcinoma of the rectum. And I think all the surgeons who are listening to this will acknowledge that really the biggest advance in the treatment of these patients was the development of the TME, the TME technique, which reduced the local recurrence rate from between 40 to 50% down to less than 10%. And we have added a little bit more with the addition of radiation. So ideally, the local recurrence rate should be less than 5%. So what is the role of neoadjuvant radiation? So this is just referring to long course. We're going to talk about short course a little bit later. Prior to this trial that was originally published in 2004, and this is the so-called famous German trial, we didn't know if we were giving long course radiation, whether it was better to give it before the operation or after the operation when you actually had the pathological stage. So this trial, interesting, only used endoscopic ultrasound and CT for staging, not MRI, randomized patients to either pre-op or post-op chemotherapy, and the benefit as shown in this graph was for local recurrence. There was also a benefit for less toxicity, but it didn't make any difference to the overall survival. So since 2004, if we're looking at long course radiation, it is always ideally given after surgery. But we need to decide which patients are going to benefit from radiation. And this is a group that was created by some radiologists in the United Kingdom based on clinical staging with MRI. So the MRI of the pelvis is critical when we're going to make a treatment decision for patients with primaries in the rectum. And they divided them into the early or good patients, the intermediate, bad, or the advanced or ugly tumors. So very simply, the early tumors are those that are resectable up front. So the stage, the T1s and 2s, the early stage 3s with no obvious pathological nodes, those could have surgery up front. The intermediate patients can have nodes, but definitely no extramural venous invasion. And their treatment, you can go either way. Some of them may be surgical candidates up front. Some may need radiation. And then the bad tumors are the T3 tumors that go more than 6 millimeters beyond the muscularis, can have N2 nodes with extramural venous invasion. And then the ugly tumors are really the mesorectal fascia is involved, or there's a node outside the mesorectal fascia. So the bad and the ugly patients are the ones that we would consider the addition of radiation to. What is short course as opposed to long course radiation? Short course radiation means giving the whole treatment in 1 week. So we give big fractions of 5 gray, Monday to Friday, to a total of 25 gray, and that's the end of the treatment. Long course is either 1.8 or 2 gray per fraction, to either 30 or 25 fractions. It's usually given with 5-fluorouracil concurrently to a total dose of 50.4 or 50 gray, depending on the fractionation. Through some complicated calculations, these two fractionation schemes are shown to be biologically equivalent. If you give short course and follow it immediately with surgery, there's no allowance for downstaging. And I can't really go into the details of which patients you would select for this treatment. It's not something we do here. So it would be a patient that was upfront resectable, and for some reason the pelvis needed to be sterilized. So I'm not going to talk very much about short course and immediate surgery. If you give short course and then delayed surgery, so wait 8 to 12 weeks for an operation, this does allow for downstaging. Long course and concurrent chemotherapy with delay surgery also allows for downstaging. And actually the results are similar whether you give long course or short course and delay the surgery. And that was proven in this Stockholm 3 trial that was published in 2017. So whether you choose short course and then delayed surgery or long course and delayed surgery really depends on the institution. We're now moving towards TNT, or total neoadjuvant treatment. And the reasoning behind looking at giving all the treatment prior to surgery is that about 30% of patients will develop metastatic disease, even if they've had a complete response, or if the primary site is clear. We know the role of adjuvant chemotherapy for primaries in the colon, so that we've talked about that before. But for primaries in the rectum, the role of adjuvant chemotherapy is not clear, especially if they've received pre-op treatment. So with bearing all this in mind, the aim of the total neoadjuvant treatment is to give all the treatment, the chemotherapy and the radiation, prior to surgery, to hopefully decrease the rate of metastases and thereby increase survival. And it's also being looked at in organ preservation, so to try and achieve a complete response so that patients avoid surgery and follow the watch and wait protocol. So these are the various options that have been looked at for TNT. You can give short course radiation followed by chemotherapy and then surgery, or you can start with chemotherapy and then give the long course radiation, or you can start with long course radiation and then give chemotherapy. And various trials have looked at all these different schemes of treatment. So in very brief summary, I'm going to look at the outcomes of 3 recently published trials. The Rapido trial compared short course radiation and chemotherapy as opposed to long course, and they could show that there was decreased treatment failure and decreased metastases, but they couldn't show an overall survival benefit. The Stellar trial also used short course radiation followed by chemotherapy as opposed to long course. And the aim of that trial was a little bit different. They wanted to show that it was not inferior, and they did reach their primary endpoint. But that trial didn't show any difference in the rate of metastases, and again, didn't show any overall survival benefit. The Protege 23 trial used chemotherapy with the combination of FOLFOX prior to long course, as opposed to just long course radiation. And they could show their primary endpoint of improved disease-free survival, but again, it didn't make any difference in overall survival. So at the moment with TNT, there's no standard approach. There are plenty of trials ongoing, and hopefully one day the ideal sequence of treatment will be determined. So what do we do here? We're very fortunate that we have our weekly MDT, so all our patients come through. The patients who have early or some of the intermediate group, referring to that previous chart, will have upfront surgery. And then for the locally advanced disease, we went through some changes, obviously with with COVID. Prior to COVID, we were giving long course and then delayed surgery. When COVID came, we changed to short course with some chemotherapy in between. And then when the waves came and went, we were going short course with COVID and then long course, and eventually decided we needed to follow one protocol and not act on whim. So our protocol at the moment is for elderly, frail patients who are not going to tolerate chemotherapy. We give the short course radiation and then delay the surgery. All other patients, and I'm talking about all others with no metastatic disease, they'll get total neoadjuvant treatment, which includes short course radiation, 4 cycles of Capox, and then surgery about a month after finishing their chemotherapy. And this last statement is because I used this slide to talk to our registrars a couple of weeks ago, and some of them are going out into the big wide world soon. So I told them it was very important that you decide on the way you're going to treat your patients if they need neoadjuvant treatment, and stick to your regimen and not chop and change. I'd like to go through how we go about irradiating our patients. So we have to be very careful that we set them up correctly and that the position that they set up in is reproducible, because obviously if they're in a different position every day, we're going to miss the tumor. Here at Crutoscale, we like to use a belly board. This shows the dip in the belly board to allow the contents of the abdominal cavity, most importantly the small bowel, to fall into this dip and be lifted out of the pelvis. We follow a protocol for bladder filling. So the patients are given empty their bladders and are given a certain amount of water so that the bladder is ideally of the same volume. And if it's comfortably full, it can also help lift the small bowel out of the pelvis. So the patients are position prone. We do a CT scan with both IV and oral contrast so that we can see the organs. And then the scan gets transferred to our planning system. We draw what's called a GTV, or a gross tumor volume, as illustrated here in the pink, although the sagittal view doesn't show it very clearly. We then put on a clinical target volume, which includes all the potentially involved nodes. So for all patients, we'll include all the mesorectal nodes, the presacral nodes, and the nodes running along the internal iliac vessels. That for the low tumors or for anterior organ involvement, we'll also include the nodes running along the external iliac vessels and the inguinal nodes. And then we put on a planning target volume, that's a centimeter around the clinical target volume, and that allows for some variation in daily setup as well as for organ movement. This is an axial view, again showing our target volume and also showing the organs at risk. Those are the organs that are going to also get a dose of radiation. So we delineate those to tell the planning computer, please don't put too much dose here because we don't want them to get a dose that's over their tolerance. And the organs at risk that are relevant for a patient with a primary in the rectum are the bladder, the femoral heads, the genitalia, and of course the bowel. Once we've done the volume, it then gets handed to the radiation therapy technologists to plan the treatment. We use a technique here called VMAT, or volumetric arc therapy, where the machine rotates around the patient and gives the machine rotates around the patient. There are special devices inside the machine called multi-leaf collimators, which move to give the shape of the area that we want to irradiate. So that arc shows the beam that's going to go around the patient. And then this colored area shows where 95% of the dose is going to fall, which is nicely conformal to the PTV, which is seen here in red. Then on sagittal section, again, the 95% falls within the PTV. We look at the dose to the organs at risk on a dose volume histogram, and there are very specific dose constraints to know how much radiation we can give to each organ without causing permanent damage. So the organs at risk are assessed on a dose volume histogram. And once we're happy with the plan, it goes through quality assurance with the physicists, and then the patient is ready to start. Just to end off the treatment of primaries in the rectum, this is hot off the press, an article published a couple of months ago looking at PD-1 blockade in patients with mismatch repair deficient locally advanced rectal cancer. So this is immunotherapy. They put 12 patients on this trial, and the trial protocol said they would get this agent, dostarlimab. I'll show you how that agent acts in a cartoon a little bit later. After the dostarlimab, they were supposed to have neoadjuvant radiation and chemotherapy and then surgery, but all 12 patients have had a complete response to just the dostarlimab, so they don't have any evidence of tumor on MRI, on PET, on endoscopic evaluation, or biopsy. So this is definitely something that's going to be looked at more in the future, but again, only for patients with mismatch repair gene defects. Just a little bit about watch and wait. We don't have any randomized trials, and by randomized, I mean looking at patients who've had a complete response to their neoadjuvant treatment and then randomizing them to observational surgery. Those trials don't exist, but this is definitely an acceptable option for patients who have achieved a complete response to their neoadjuvant treatment. And these patients require very careful follow-up, both clinically, with endoscopy and biopsy, and with MRI to make sure that there isn't any recurrence within the pelvis that can't be seen on endoscopy. I'm going to move on to the treatment of metastatic disease. And again, here's this table showing the cytotoxics, the biologicals, and the immunotherapy. We'll go through the mechanism of action of some of these very briefly. There are two anti-epidermal growth factor receptor agents called cetuximab and panitumumab. Basically, they come and sit on this transmembrane receptor and block this pathway which promotes cell proliferation. Very importantly, before this treatment is explored, one has to look at the gene coding for this group of proteins, the RAS protein, because if that gene is mutated and this protein is abnormal, these agents are completely ineffective. So RAS is a predictive biomarker. It will tell us which patients are likely to respond to these two agents. Then there are a number of agents that interfere with the blood supply to the tumor. So obviously, if a tumor is going to grow, it needs an adequate blood supply. They have different mechanisms of actions. You probably heard about bevacizumab, but there's some other ones, aflibercept, regorafenib, and ramucirumab. And then a very brief and simple explanation of how the immunotherapy agents work. So our T cells are unable to recognize tumor cells as foreign because some of them have this PD-L1 or PD-L2 receptor. By giving PD-1 blockade with an agent such as pembrolizumab, it allows the T cells to recognize the tumor as foreign and then mount an anti-tumor immune response. These agents for colorectal cancer are only effective in the patients with mismatch repair gene defects or microsatellite instability. For patients who have upfront resectable colorectal liver metastases, we can choose to either give peri-operative chemotherapy or post-operative chemotherapy. The biologicals have no role here. It's either FOLFOX, Capox, FOLFIRI, or Peri. When if you take an overall approach to this, we don't really have much evidence for it. There's a meta-analysis that shows there's a benefit, but it's not statistically significant, and another systematic review which has a benefit for progression-free survival. And so despite the lack of evidence for overall survival, guidelines generally recommend chemotherapy for a 6-month period. This is the graph from the peri-operative chemotherapy published a long time ago, showing that if they took the ineligible patients out, there was a benefit for progression-free survival, but no benefit for overall survival. To move on to the treatment of potentially resectable liver metastases, so those that will need some treatment to shrink the liver metastases, or those patients who have completely unresectable metastases, we need to look at the biology of the tumor because this is where the biological agents are indicated. So depending on whether the tumor started on the right or the left, there's a continuum of a sort of slightly different biology. Patients that have tumors starting on the right are more likely to have BRAF and KRAS mutations. They're also more likely to have microsatellite instability. Whereas if they arise on the left, they're less likely to have the KRAS and BRAF mutations. But it doesn't mean that there's an absolute cutoff there. There's a sort of continuum of the biology of the tumors. So if we're going to talk about conversion chemotherapy in a patient that has liver metastases that are too large for resection and we need to shrink them, it depends on where the tumor arose and the mutations. So if the tumor is on the right, and definitely if it's got RAS and BRAF mutations, we add bevacizumab as the biological, and that can be added to any of those chemotherapy regimens. Even if it's KRAS wild type, your first treatment would be with bevacizumab and one of these doublet chemotherapies. However, if the tumor rises on the left, and we've shown that RAS and BRAF are wild type, then we can add one of the anti-epidermal growth factor receptor agents to either FOLFOX or FOLFIRI. These agents, cannot be used with capecitabine. We have to use infusional 5-FU. So if we look at all patients with metastatic disease that don't have upfront metastases, we need to look at the patient's clinical condition first. If they're very poor performance status, we're going to offer supportive care. If they're unfit for combination chemotherapies, this was published in Europe where they have the biologicals, you just give a fluoropyrimidine and one of the biologics. And if they're fit for combination, then you need to take the tumor location and the mutational status into account, as I showed on the previous slide. For second-line treatment with all those agents available, you can choose from a number of regimens if they're available, but it's not for us where we're a little bit resource constrained. But depending on the first-line agent, because all patients are going to progress on those, then you can give numerous different second-line agents moving on to third and sometimes fourth-line treatment. And what this has meant for patients with metastatic disease is that the median overall survival has increased from about 12 months when we only had 5-FU up to 24 to 30 months if you can use everything that's available. I'm going to move on to treatment of adenocarcinoma of the pancreas. My approach is going to be more or less the same. This is a list of the active agents, which are very similar to colorectal cancer, but here we've got gemcitabine and cisplatin, and then an agent called nab-paclitaxel, and the only biologic that's effective are the PARP inhibitors, and that's only in patients with the BRCA mutations. Some of these can be used in combination, so we can combine capecitabine and gemcitabine. If we combine 5-FU, irinotecan, and oxaliplatin, we've got FOLFIRINOX. Modified FOLFIRINOX just means no bolus 5-FU and a slightly lower dose of irinotecan. And then nab-paclitaxel and gemcitabine can also be combined. A few slides on adjuvant treatment. So these are probably going to become historic because, again, in primaries in the pancreas, the world is moving to neoadjuvant treatment. One of the earlier trials took patients who'd had surgery and randomized them to gemcitabine or observation and could show a benefit in survival for the gemcitabine patients. We had the SPAC1 trial, which had quite a lot of criticism because of the trial design. There were 4 arms: chemoradiotherapy, chemotherapy, a combination of both, or observation. And one of their findings was to show that the patients who had chemoradiotherapy actually did worse. So for all the future SPAC trials, these were done in Europe, they did not include radiation. The SPAC3 trial compared 5-FU with gemcitabine, found no difference in survival, but the gemcitabine was better tolerated. And then SPAC3 combined gemcitabine and capecitabine and compared it to gemcitabine and could show benefit for overall survival. So this regimen was accepted for a short period of time because this was published in 2017. But a year later, the FOLFIRINOX trial was published, and this compared the modified FOLFIRINOX with gemcitabine and showed a big difference in median overall survival numerically, and this was also statistically significant, but with the addition of a large percentage of grade 3 to 4 adverse events. If we're looking at adjuvant chemotherapy, we need to select our patients. So for colon cancer, remember, it was only the high-risk stage 2s and stage 3s. For patients with primary in the pancreas, we offer it to all patients, no matter what their pathological stage is. But the choice of regimen depends on the patient's performance status and the comorbidities. If they're very well, we would offer modified FOLFIRINOX. If the performance status is a bit higher and they have some comorbidities, we give the combination of capecitabine and gemcitabine. Or if we can give single agent gemcitabine or capecitabine if their performance status 2. And our choice of regimen really depends on where the patients live, because gemcitabine is a weekly IV regimen, whereas capecitabine is a 3-weekly regimen. So to talk briefly about neoadjuvant treatment, there has been one randomized trial published. It was in the Netherlands with almost 250 patients. All patients were resectable up front, and they compared giving pre-op chemoradiation versus, and then followed by adjuvant chemo as opposed to upfront surgery and adjuvant chemotherapy. The chemotherapy was gemcitabine. So that's the scheme before surgery, and the patients who had surgery up front just had adjuvant gemcitabine. And the final results did show a survival benefit for the patients who received the neoadjuvant treatment. So this trial has had some observations or some hesitation. It hasn't been widely accepted because the gemcitabine is not the favored chemotherapy regimen now that we've got FOLFIRINOX. So there are plenty of trials ongoing looking at different ways whether to, we don't know the optimal approach, so we don't know which chemotherapy regimen we should give. We don't know if the addition of radiation is going to be beneficial. The ASCO guidelines in the United States state that you should only do this on a clinical trial. The NCCN guidelines say to consider it in high-risk tumors, and in Europe, neoadjuvant treatment isn't even discussed. What have we done here? Well, we've adopted the neoadjuvant treatment. If the patients are good performance status with no significant comorbidities, we've offered the modified FOLFIRINOX. That's the omission of the bolus of 5-FU and a lower dose of irinotecan. When we were dealing with COVID and we couldn't admit the patients, we gave Capox, which is still 5-FU with oxaliplatin, but no irinotecan. And the patients who are of worse performance status or comorbidities, we've given single agent, either capecitabine or gemcitabine. We've had about 30 patients coming through, outcomes not that exciting. Only 3 patients have been resected after modified FOLFIRINOX. 2 patients actually after single agent gemcitabine and capecitabine. I'm actually only aware of 1 patient who's in long-term follow-up. And then we're going to end with the treatment of metastatic or locally advanced disease. In the late 1990s, this trial was done comparing gemcitabine with 5-FU, with a small benefit in overall survival, but a big benefit in clinically, with patients saying that their pain was improved, their performance status was improved, and they gained weight. And then for more than 10 years, numerous trials were done adding agents to gemcitabine or comparing other agents. None of these trials showed any benefit until this trial came along in 2011. And this randomized patients to the full FOLFIRINOX regimen as opposed to gemcitabine, with a difference in overall survival, but with the impact of toxicity and on quality of life. And then another trial that used a combination of nab-paclitaxel and gemcitabine as opposed to gemcitabine alone could also show a survival benefit for the combination, with the adverse events slightly lower than the FOLFIRINOX. So what the choices are for patients with metastatic or locally advanced disease. So just again, these trials actually only looked at metastatic disease, but these regimens have been translated into those patients with locally advanced disease. So if the patient is a good performance status with no comorbidities, they can get FOLFIRINOX. If you're worried about comorbidities, the performance status is a bit worse, you could offer nab-paclitaxel and gemcitabine. The nab-paclitaxel we don't have available here. And if the performance status doesn't support these two agents, then we can give either gemcitabine or capecitabine, depending on where the patient lives. My final slide is on the role of radiotherapy in patients with adenocarcinoma of the pancreas. It's obviously being considered in neoadjuvant treatment. For adjuvant or post-op treatment, it's used quite a lot in the United States. There are some old trials showing some benefit and some retrospective studies. And then for palliation, if the patient has only got locally advanced disease, and we've done a staging laparoscopy to exclude small peritoneal metastases that are possibly not visible on CT, we can offer a higher dose of radiation for local tumor control. So that would be about 45 gray and 25 fractions. And that would just be to offer for local control, but definitely not curative. And then palliative radiation is very effective for managing pain and for managing those ampullary tumors that bleed continuously and are transfusion dependent. Thank you very much for your attention.
Thank you very much. I think Marcus had to go. I think he has load shedding. Do we have any questions for Dr. Robertson? I see one question in the chat from Mohammed Saro. Thanks for the talk, and he'd like to ask about the evidence of FOLFIRINOX in adjuvant setting. He means in neoadjuvant setting. Does that make sense?
Yes, so we don't know that. As I said, it's being used in trials, but we do, as I said, that's what we use here. We know that it's an effective chemotherapy regimen, but we don't know if it's the best regimen. So that's what we're using here, and I'm sure there's some trials that are going to come out soon that will show us whether that's the right approach or not.
And there's a second question. What is your thought about liver-targeted chemo in CRCLM?
Yeah, in colorectal liver metastases. Can I ask for an explanation of what you mean by that?
Sorry, do you hear me?
Yes, I can.
Yes, thank you for your talk, and thanks, Carrie. I'd like to ask about the role of hepatic artery, intrahepatic artery chemotherapy, like hepatic artery,
so
infusion chemotherapy.
I don't have any experience with it. I know it's an acceptable form of treatment, but I'm the wrong person to ask. I'm not aware that we're using it at all at Groote Hospital, and I certainly don't have any experience. I know that it's acceptable. I'm sorry, that's what I can tell you.
Thank you. Yeah, I have another question. Sorry for these things.
No problem.
So my question is that what is your thought about those who fail the chemotherapy while they are like they have progressive disease while they are receiving the chemotherapy after colorectal surgery? For example, the patient have colonic resection and they received adjuvant chemo, and while he is receiving the chemo, he developed like early metachronous liver metastasis. like while he's taking the chemotherapy, the patient developed the liver metastasis. So what are the options? And if we completed the 6 cycles of chemotherapy, what else left?
So if we picked up that a patient was progressing on chemotherapy with only liver metastases, we would bring that patient's scans through the HPV MDT and ask if the liver metastases were resectable. And obviously if they were, then they would go on and have surgery. If they're not resectable, we would change to second-line chemotherapy. We change our chemotherapy regimen. But I think, you know, from the surgical point of view, that tumor biology is very bad. If the liver metastases are developing on chemotherapy, I think they'd be fairly hesitant about going in and operating.
Thank you. Thank you so much.
Do we have any other questions? Perhaps you can raise a hand.
Hi, Dr. Robertson. This is Yalda. Thank you
Hi,
for the
Yalda.
very nice talk. Hi. My question is actually not with the colorectal or pancreatic. I'm having a question regarding the role of chemo in the neuroendocrine tumor. So I know that we usually give a chemo in a grade 3 neuroendocrine tumor here. But when I was reading the ENET guidelines, there is a role for some sort of a chemo in grade 1 and 2 tumor. I just wanted to know your opinion in that regard.
Yeah, I think for the certainly there seems to be some evidence for certainly the pancreatic tumors for cytotoxic. You're talking about cytotoxic chemotherapy as opposed to some of the biologicals.
Yes.
Yeah,
we're mainly talking about the streptozotocin.
Yeah, I don't think that's available here. We tend not to give it. The patients, as you know, with the grade 1 and 2 tumors usually fall between you and nuclear medicine. And it's only the poorly differentiated neuroendocrine carcinomas that we offer chemotherapy to. But there does seem to be some evidence actually for FOLFOX in some of the grade 2 tumors.
Okay,
again, you know, with virtually, yeah, I can say no experience here. I can't give my personal opinion. I know that it is discussed in the guidelines.
Okay, thank you so much.
Any other questions? It looks like you've answered all the questions then, Dr. Robertson. I'd like to thank you so much for being our presenter today. Thanks to ECHO University of New Mexico and the ECHO India team for the support. The feedback form is available in the chat, and the recordings will be available on the Gastro Foundation website. And next week's topic is colorectal. That's as much as I am able to tell you for now. So if there are no further questions, we'll say thank you very much. Thanks all for joining us today.